start recording. So we are on February 2nd, 2021, and this is for PTA103, which is your modalities class. I know from teaching this class in the past that it seems like the first couple lessons don't make any sense at all. Why am I learning about inflammation and repair, or why am I learning about pain control theories when I'm supposed to be learning how to do ultrasound on a patient? And I can completely, just empathize with you. When I first took a modalities class way back when dinosaurs roamed the earth, it definitely confused me because I didn't, why do I have to know about primary intention repair and secondary intention repair? Why do I have to know about this? Why do I have to know? I just need to know what my ultrasound settings are. But if you don't understand inflammation and tissue repair, you could do the wrong ultrasound and actually make it worse, or you could do the wrong e-stim and actually make it worse. That's one of the reasons we cover this. The same thing with pain control theory, which I think is your next lecture in this class. If you don't understand the primary pain control methods and you use the wrong pain control method on a patient, you can actually end up making the patient worse. So that's why we kind of go over this in this method. So can everyone see the PowerPoint? I got my screen shared. I saw you there, Riley. Don't worry about it. I caught you. All right, we got. All right, so you guys, I know because I taught this class concurrent with the this is like 2 semesters ago. I taught this concurrent with when I was teaching patho, so I know these chapters relate quickly. So if there's a section where you guys are like, okay, Mr. McKeever, you have beat this horse until it's glue, move on. Let me know. Like if it's something you guys grasp from Dr. Sokel's class, let me know. I'm going to try to go through it fairly quickly for you guys because we have about an hour and a half. But don't hesitate to say, got it. You don't have to explain this anymore. So when we're going through the phases of inflammation and healing, right? So first thing happens, we get an injury. So let's say, this is more, and you guys got my nice background for my Tucson house here today. So if you're confused, it's not that I'm moved yet. This is my other house. Let's say I'm walking through my house here today and I trip on a throw rug. And when I trip on that throw rug, I turn my ankle really bad inward. The first thing that's going to happen is my body is going to have to determine, is this a serious enough injury to worry about, or is this something that we can just let go? Right? You've all done that where you've turned your ankle and for a couple minutes, it's sore and achy, and then it just kind of goes away. You're like, okay, I got that. But what happens if when I turn my ankle like that, I actually tore some ligaments? Well, now the body's got to begin the repair process. So that's where you move through these phases of inflammation and healing, right? So we're going to look at how in rehab, we treat patients that may have had inflammation from trauma, surgical procedures, patients that have problematic healing, and then how those modalities, when you say physical agents in therapy or rehabilitation, we're talking about modalities. And we'll even talk about massage, and you wouldn't think massage is a modality, but it really is. It's not your standard stretching exercise, stuff like that. It really is an adjunctive modality we use. Therapeutic exercise techniques and some manual techniques that we have out there for it. So when you injure yourself, the first thing you're going to go into is that inflammation phase. What are some signs of inflammation you guys have learned about?
Redness, swelling.
Redness, swelling, right?
Vasodilation.
Yeah, vasodilation. Heat. And usually the one that most patients complain about is the what?
Pain.
Yeah. Pain. That is going to be your mantra for most of your career in physical therapy is, okay, what's your pain level today, Bobby? Oh, I'm at a 10 out of 10. Really? You're sitting here chewing on your beef jerky and you're fine. Yeah, it really hurts. Okay, Bobby. But the inflammation is a natural process, right? The swelling that happens, it's a natural process. All of that should last less than a week, that full inflammation phase. Now, when we talk about these different phases of inflammation healing, it's kind of funny because I just covered this with the other group dealing with wound care. While we say 1 to 6 days, it doesn't always necessarily mean it ends at day 6. Sometimes it can go to 6 or 8, depending on how bad the injury is. And a proliferation phase starts at day 3 and goes to 20. Well, it's not a hard 20, could be 2 months. But these are kind of the standard set phases. And we get to that maturation phase or the remodeling phase And that could last years. So the settings aren't exactly hard, but what they help us understand is if the patient's in the inflammation phase, we know they're in an acute phase of injury, right? If they're starting to move to the proliferation phase, I talk about moving them into the subacute range of injury, where they're starting to get out of that immediate need of danger. And they get to that maturation phase, they're more in the long-term phases of healing. And there are different modalities for each of those phases. But in the inflammation, it prepares either the wound, the injury, whatever it is. And I'll use wound here as a common term because that's a really easy one to see. You get a cut on your arm, right? You get a nice cut on your arm. You can see the inflammation. The wound edges kind of raise up and it gets a little warm, right? And it's going to bleed at first, right? That's that vasodilation occurring. The bleeding is trying to push out any contaminants, making sure you don't get infected. And then it's going to stop bleeding and it's going to vasoconstrict. And that's to allow that clot to form. All of that's setting your body up to move down through these phases. The proliferation phase is where we start rebuilding damaged structures, right? If you have a wound that's there, it's going to start laying in some groundwork and some matricing to heal that wound. If you have a torn muscle, it's going to start laying down some groundwork to make that muscle viable again. And then the maturation phase is also synonymous with the remodeling phase, where it's remodeling the tissue to get back to normal. And it's where the scar tissue, the injury itself, starts taking its mature form. And again, they do overlap, and there are some things in between as we go along. This is kind of a look at it from a graph standpoint. I don't like graphs myself, but it shows how they kind of overlap with each other. So inflammation comes from the Latin inflammer, which is to set on fire. We have the heat, redness, swelling, pain, and loss of function. Why do you think in the inflammation phase, we get loss of function? What's the body telling you to do?
Stay off.
Yeah, right? You sprain your ankle and it swells up and you can't walk on it. The body's saying, hey, numbskull, stop walking on that ankle. You hurt it, right? The body is telling us what it can do. Now, sometimes that can be good and sometimes it can be bad. The pain itself, does the pain itself actually come from the injury, or where's the pain come from?
The neurons.
Right, yeah, pain comes from your brain. This is a really kind of high level therapy thing that if you guys could get your brain around this, it can really help you in treating a patient and telling patient, and you don't want to tell them it's all in your head. All that pain is in your head, but it really is. Think about it this way. We talked about spraining my ankle. Let's say instead of I'm in my house, I'm now down on the streets of Las Vegas, and maybe I'm crossing over Las Vegas Boulevard, or on one of the areas where you actually physically cross. I step down off a curb and I sprain my ankle, and I sprain it really bad to the point that I can barely walk on it. Now I pick my head up and I see some idiot driving his Hummer at like 100 miles an hour straight at me. Am I going to be able to probably walk on that ankle?
Only if adrenaline kicks in.
Right. The body is going to say right now that danger is worse than this danger. And it shuts off your pain circuits. And that just goes to show that, okay, a lot of that pain is in our head, right? Especially when we're going to talk about chronic pain and chronic patients. That really gets stuck in their head that I should be in pain, so I'm in pain. I always love when we talk about, like inflammation phase and you hear the person, I've got a hot pain tolerance. What's your pain level? 10. Okay, sure. Right? But that just shows that a lot of that pain effect is in our head. And all that really is the body saying, flashing red light saying you did something down here. So same idea, that Hummer's coming rushing at me. I suddenly can walk on my leg, get back up under the curb and avoid him. As soon as that threat has passed, now my brain's going to say, threat passed. Okay, now what did you do to your ankle? And now the pain's going to come in. And it's amazing the way the brain can work like that. The brain can override a lot of stuff. If you look at the way, there are all kinds of stories of mothers lifting things off their children and stuff like that. The brain does some pretty impressive stuff. So begins the normal physiology of tissue is altered. That's the inflammation phase. It's an attempt to dilute, destroy, or isolate any agents that might be at fault. It's necessary for healing. but it also can be chronic inflammation where you can't get out of it and it doesn't allow healing, right? Autoimmune disease are great examples of a patient being stuck in an inflammatory phase, right? Where the autoimmune system, your immune system, your own body decides it's going to attack itself. Does anyone know any autoimmune diseases?
Rheumatoid arthritis.
RA is a great one. Yep. And what's the one that House always tries to put on every single patient? Does anyone know? It's got to be lupus. Lupus is everything. If you know, House, the TV show, great doctor, great bedside manner too. Lupus is another one, right? Juvenile rheumatoid arthritis, another autoimmune disease. That's your body attacking itself. That's your body getting stuck in that inflammatory phase and destroying itself. And it's amazing how when you get stuck in those inflammation phases, how it can actually destroy your body. My ex-wife, or my wife that passed, had an autoimmune disease called mixed connective tissue disease. Mixed connective tissue disease is when they don't know what autoimmune disease you have. They don't know if you have sarcoidosis. They don't know if you have lupus. They don't know if you have fibromyalgia. You've got symptoms of all of them. So we're just going to call you mixed connective tissue disease. And that disease broke down her body over time until the point where her spleen literally ruptured on her and she passed away. That was her body being stuck in that constant state of inflammation. She was constantly in pain, or so she thought, but what it really was is being constantly in inflammation. So when we're talking about this, right, when we're in this inflammation phase, the one thing I want you to think about when you're looking at your boards or looking at anything, whenever you see what I call the EAMs. So if you look up here, we have histamine, kinins, prostaglandins, cytokines. All of those are mediators of inflammation. All of you have gone out in a, sorry, some of you, maybe you don't have allergies, but like me, on a nice spring day, you go outside and the flowers are in bloom in Vegas and you're outside for about 30 seconds and what happens to your nose? I'm stuffed up, right? All those inflammation things kick up and your nose gets stuffed up. And then maybe you take an antihistamine in order to calm down that so you can actually go outside and not feel like you're drowning in your own snot. The histamine and that vascular response is normal. Why do we get allergies? What is the body trying to do? Why does it swell up our nose so bad and give us that nasty mucus? What's it trying to do?
Secrete.
Yeah, it's trying to secrete stuff because it thinks that that pollen and stuff coming in your nose is a foreign invader. And so it's saying, nope, not invaded on my turf today. And so it's going to protect you. So it is a normal response. There's also going to be that hemostatic response where it's going to either, first of all, vasodilate to clean out the wound, and then it's going to vasoconstrict to reduce blood loss. And this is a great example if you get a bloody nose. When you first get that bloody nose, it's bleeding like crazy. And then as it slows down, it stops bleeding, stops bleeding, stops bleeding. Eventually, it'll clot up. That's a normal response with inflammation. At the cellular level, those leukocytes, those white blood cells, migrate to the area and clean the area of debris. You just talked with, when I was in anatomy the other day, with Dr. Johnson talking about the mediators of inflammation in the neurosystem. Well, these are the mediators in the immune system, right? The leukocytes and all those white blood cells come in and clean out the area. They are literally the eaters of the dead tissue, and they'll clean it up. The neutrophils come in, activate other infection-fighting cells, and it acts as a complement to all the rest of that inflammation phase, meaning as it works through it, each section, so the inflammation is going to work with the hemostatic. The hemostatic is going to work with the immune response. The immune response is going to even work with those inflammation mediators. So just kind of looking at this here, right? We have vascular response to wound healing. If we cut a vessel, this is kind of what it looks like that happens. So we've got our plasma, we got our red blood cells, we got our white blood cells, all that stuff in there. The body's going to try to move off as much of the blood as possible and move those clotting agents to that wounded edge. Now, in cases of something like a stroke, where you have a hemorrhagic stroke, where the blood vessel bursts in your brain, the brain doesn't have the ability to shut off that bleeding. That's where you end up in trouble. Yep, fighting bacteria, exactly, Raquel, right? The fighting bacteria comes along. That's what those, anytime you look at those leukocytes, the white cells, their job is fighting off. They are literally your knights in shining armor coming along to fight any type of bacteria, any type, and it's not only bacteria, but any invaders, because you could also have something like a fungus, right? You guys all heard about the mushroom that walked into the bar, right? Walked into the bar and the bartender said, "You can't be here." And he says, "Why? I'm a fungi." No, well, tried. So you missed my humor. But all of those, the white blood cells are going to fight all of those, the bacteria, the viruses, right? My arm right now is sore as all get out because I got my second dose of the COVID vaccine yesterday. All right, I got a laugh from a couple of you. Literally right now, my abduction is limited to about there. I can't really get much past that because my shoulder's a little swollen from the shot. That's a normal reaction. And I've heard people with this vaccination. Yep, okay, no problem, John. I've heard people with this vaccination get a little upset because they're like, "Oh, I feel like crap after the second vaccination." And I'm like, that's good. That's your inflammation system saying, "I recognize this, and I am now developing a lock and key method to treat this disease if it invades me." That's what we want. And then if it doesn't react and you don't get sore, like I have a couple of PT friends that I'm jealous of, they got the vaccines and absolutely nothing happened to them. They're like, "Yeah, I was a little sore for the day, but I feel fine." I kiss my butt. I got, like, this arm is really sore from the second vaccine. Maybe it's just some whiny baby, but whatever. But I know that's my inflammation system kicking up and building up those immune mediators in case the vaccine or the real virus gets in. So here we have those white blood cells coming in, right? They're going to come in, they're going to find the source. They're going to find this little break here. They're going to go out here and pass that basement membrane and then attack any type of those viruses or bacteria that might be out here. Your pimples on your face are a great kind of source of this, right? I'm sure all of you had a pimple at some point. It is all in my head, actually, right? The pain itself is, I know that, but it's still annoying. If you've ever had a pimple, right? That white mucousy substance, the whitehead in your pimple, if you ever get one of those pimple whiteheads out and they're kind of chunky and it's like sour milk looking, all that is white blood cells. Those white blood cells came in and encased the invading force that blocked up your pore and basically put it in a case in a little shell for your body to eject it from the body. That's an immune response. The human body has some amazing ways to deal with invaders, right? So here's that macrophage, and macrophages are our major eaters of the dead. Do you guys remember what the wound mediators in the brain were called? Which ones you had in the brain that dealt with that? From Dr. Johnson's lecture? Because remember, you had your Schwann cells. Remember all those? It's too early.
Is it the one with the nutrients?
Yes. Which one's that?
Astrocytes?
Astrocytes. Right. Yeah. Right.
With the A, but
Yep. So all those. So the difference is when you're talking about the sites, that means cells. So astrocytes is their name for the way they look, right? But they all do the similar thing. So in your brain and in your nervous system, they act the same way as this macrophage does. The macrophage is going to come and find it. And like I said, that pimple in your face is a really excellent example of it. Or maybe you have a pimple elsewhere. Maybe you have back pain. I don't know. What causes pimples to happen? A lot of times it's because pores get blocked with foreign material, right? That's why there's $1 million empire right now to sell you stuff to fix every pimple on your body. But the macrophages come in and say, okay, there's that foreign body. I'm going to swallow it up. And hopefully the goal is it'll either do one of two things. It'll either lyse that material and literally just eat it and destroy it. And you'll have a little bit of that, if you have a pimple, you'll have a little bit of leakage of white blood cells that are dead white macrophages. Or maybe you get a thick chunk where it's encased it so the body can reject it. Same idea here is going to happen anywhere in the body. If I get a cut on my arm and somehow staph gets into my cut, right? Staphylococcus, which is a virus or a bacteria. If it gets into my blood, the body's going to do the same thing. It's going to send macrophages to that area to try to delete, to destroy that bacteria before it goes systemic. They're really good at this. So then once we kind of get out of that inflammation phase, that wound kind of calms down, the next thing we're going to go into is the proliferation phase. And I like to think of proliferation as the building phase. This is where the body's going to say, okay, what do I need? And it's going to start calling in construction workers. And it's going to start calling in people saying, okay, I need you to fix the skin. I need you to lay down a wound matrix. I need you to build some blood vessels. And we have specific contractors in our body that handle all of those, right? You wouldn't want, if you're building a house, you maybe wouldn't want the guy that's laying the foundation to be the one to put your roof on, because he's probably specialized in laying foundations. And the guy that does your roof is specialized in building your roof. May not go the best if you decide to let the guy that builds your roof lay your foundation. Same idea here in the body, right? We have different tools that are going to go along. So we have the epithelialization. Epithelialization is the laying down of that new tissue. And usually when I think of epithelialization, I think of the epidermis, right? The outer layer of our skin. And we get a cut and it's got to come in and say, okay, I've got to put some new skin over that area, right? If I get a cut, I've got to put that new skin over that area so that I can protect everything inside of it. That goes along with wound care. And one of the things we used to do, and I maybe some of you still have parents that did this, and it was, you know, when my generation growing up, we used to say, keep that wound open to the air. It does it good leaving it open to the air. Did anyone ever hear that before? Or just rub some dirt on it. That's another famous one from my age, right? That sounds like a logical thing to do. Let me pick up stuff from the ground. Now, if you have nothing else to cover it with, mud actually isn't a bad option. You know, if you're in the military in the middle of a jungle and you've got an open wound, probably not a bad idea to cover it with some mud. But, you know, picking up dirt's not exactly the best idea. I'm just saying. With wound care, and we just talked about this with the other cohort, the main thing we focus on with wound care is keeping the wound covered, keeping it warm, and keeping it moist.
Sorry, it's a really random question. I was thinking
Yep.
about it when you were talking about microphages, because I pronounce it in my head as microphages.
There's not a real, so, and that's the funny is I have it depends upon where they're taught. So you'll hear me a lot when I'm in anatomy, I refer to the neck as the cervical region. And that's because my professor that taught me that was English. And for some reason, I can't get rid of that one. Like, I'll be like, yes, the cervical region of the, and they're like, what area are you talking about? So there are.
It's not just in your class. Like there have been a few classes where I've read things and they're like pronounced completely different than what I was thinking in my head.
Okay. Is there a way to do this? I don't know. I'd have to, let me get back to you on that. I think there is some stuff that has that. I have to look because I don't teach the med-term class. I really don't. I mean, assuming there's something, there's probably an app for that, I'm guessing somewhere. Let me look at that. I'll put that down as a review. So hold on. I'll get back to you on that one. So hold on to that thought. Let's say I have a really deep wound in my arm. So I've got a cut. Maybe I was out working the farm and I was doing rope and that rope just cut me right down through my dermis. Well, I've got to somehow fill in now all that area. So the body's going to come in and lay down a collagen matrix, right? And the collagen matrix is basically, you know, you can think about it. If you ever saw like a building before it's got walls up, it's just this shell. Well, the collagen matrix is going to come in and lay like that. And it's going to come in and lay crosshatch so that as it builds and builds and builds on it, there's something to hold it together. Ideally with wounds, we would like the wounds to close from the outside in. If the wounds close from the outside in, right, so the edges get approximated, it minimizes your scarring and you're less likely to get a really, really nasty scar. If it can't do that and it fills from the inside out, it's oftentimes that you end up with those really nasty scars like keloid scarring and stuff like that. But no matter what happens, we have to have this neovascularization. We have to have new blood vessels. Because let's say I get that cut on my arm and it fills in with the collagen matrix and I'm starting to re-epithelialize over, I'm getting some nice skin. But then the body doesn't put any new blood vessels in that tissue. What's going to happen to that tissue in a few days if it's not getting blood supply nutrients?
Dies?
Yeah, it's going to die, right? It's going to necrose. So then I'm looking at my wound, I'm going, and this happens in real life, actually, in wound care, because I do wound care. That's kind of the reason why I'm talking about this one. You know, maybe the patient gets a really nice, the wound looks like it's beautifully healing and everything's laying down and it looks so good. And then a week later, we're looking at the wound and the tissue's all black. And we're like, what happened? Well, what happened was the body didn't neovascularize and didn't bring in new blood vessels, maybe because they have a compromised vascular system, right? They might have an artery disease. You know, they might have high cholesterol, something along those lines. And so those blood vessels didn't come in. And now you've got an area of local necrosis and it's all just dying. And at that time, then we may have to excise it, or if it's bad enough, we may even have to amputate a limb, right? Somebody's got a diabetic toe. A lot of times we have to amputate them. Yes, Bart.
Oh, sorry. You said that when we have like a cut or something, we're supposed to keep it moist, not like dry out.
Yep.
How come again?
Well, so the wound itself, the wounds in the human body heal better when they're moist and have adequate fluid to them. Now, does that mean if I've got a cut, I should pour water on that cut? Well, I mean, it doesn't hurt. It's not going to kill it, right? But a wound that's dry, and we're going to talk about healing by primary and secondary intention coming up. A wound that's really dry, when it lays down this new collagen matrix, it doesn't heal and bring those edges in a lot. And so it ends up healing from kind of the bottom out, and you end up with kind of nasty scars.
Okay.
So the moisture you can keep, I love that word moist because it makes somebody in this class really, really uncomfortable. The warmer you keep it at body temperature, you keep the wound moist and you keep the wound covered, it'll heal nicely. And when we do wound care, that's one of the things we do is we'll actually donate moisture to the wounds. We'll add, there's different types of chemicals we can add. We can add just regular saline, you know, saturate the gauze that we're putting in the wound and then just put a cover over it and let that moisture kind of help that wound stay nice and moist.
Okay. I think my, how I'm looking at it is like a diabetic person. Maybe if they had a wound on their heel or something, moisten stuff.
So
obviously you probably can't put pressure because it's soft, right?
Yep.
And it'll just cause a deepening of the wound.
And so that's where we have to walk a delicate balance, because even, let's say I have a diabetic with a heel wound, right? And actually most diabetic wounds are going to be on that bottom plantar surface of your foot.
Mm-hmm.
If I've got a diabetic wound down there, and I actually just literally just talked to the other class about this, we have to keep that wound moist while also not keeping the area around it too moist. Because let's say I'm donating moisture to that wound, but for whatever reason, I put too much in it and now I'm getting the whole heel kind of moist.
Mm-hmm.
That's going to macerate that skin. And maceration, if you've ever gotten in the bathtub and soaked for about 4 hours because you're like, oh, I love this. This is great. And you look at your fingertips and they're all wrinkly.
Mm-hmm.
That's maceration. That's when the skin gets too moist. Now for you, you know, an hour or so later, your skin's fine. But if you have somebody that's already got compromised system, like a diabetic, that maceration may not go away. And it makes that skin really easy to tear.
Mm-hmm.
So that's where we have to walk that delicate balance. So we want to keep the inside of the wound bed moist and then just keep the skin moisturized, right?
Oh.
Does that make sense?
It does. My grandpa had that.
Yep.
He was diabetic and then had a wound on his heel, and he couldn't walk just due to being overweight, and they wouldn't even want him walking yet just because of the wound.
Yep.
Really, they would just do like little simple exercises, but I remember like watching them every time they would like scrape the wound, like, I don't know, I think it was like every week or something, but I was just wondering. I never.
Yeah, so like in your grandpa's case, if I was seeing him, and it depends on the PT or whatever that sees it. One of the things we're going to do is we're going to clean it out. We're going to debride it, get rid of all the gunk, right? because any gunk that's in there is going to cause problems. So we got to get rid of it. We got to debride it. Then I'm going to pack that wound with something that keeps it moist, but not too moist. And I'm going to try to keep it inside that wound. So then I'm going to put a coverage bandage on it. So anything that I keep inside that wound stays in that wound. And then I try to keep protection for the surrounding area. Now, they're right. They're not going to want him to put weight on it because we find a lot of times, especially with diabetics, we have to offload it, which means take the weight off of it so it heals a little better. Because what diabetics do is a lot of times don't have that feeling in that foot and they'll just walk on it. And then that injury gets worse because it breaks down more of the skin. One thing you'll find with, you know, any type of wound or injury like this is dead tissue likes to breed dead tissue. So if one area kind of gets dead and necrotic, it likes to spread. And that's why a lot of those patients that have diabetes end up losing their foot, right? Because they got a little puncture diabetic wound on their toe, and then that gets infected and kind of spreads through the whole foot, and they end up with an ankle disarticulation. And it's really hard. It's really hard for diabetics, and that's because of the blood sugar and everything else on top of it. That just adds more to it. And then with the diabetes, your body is already in a pseudo state of inflammation to begin with. Your chemical mediators are kicked up because your blood sugar is high. So that makes wound healing, much worse. And actually, for most diabetics, they heal about 5 times slower than a normal person. So, if your normal inflammation phase is 6 days, it might be 30 days for them.
Yeah.
And that can be really difficult. And it gets really frustrating for the patient. We understand it. We're like, okay, look, it's going to go. But the patient's just like, why is this not healing? I'm doing everything you're telling me. And it's just not getting better. And it's really frustrating.
Mr. McKeever, can I ask, why does dead tissue breed more dead tissue? Like, do the cells talk, like quote unquote, talk to each other?
Well, so what happens is once you get some sort of tissue that dies off, like let's talk about somebody that gets something like gangrene, right? And once you guys, if any of you ever get to smell gangrene, you'll never miss the smell of it ever again. It's a beautiful floral aroma. But what happens is, and this happens actually in the brain too, with tying to Dr. Johnson's class, once that tissue dies off, it kind of forms a rim close to the healthy tissue. And what happens is that healthy tissue starts seeing that dead tissue and say, hey, maybe I should scar off a little bit more so that it doesn't get any deeper. And our bodies just aren't that smart at that point. So it just kind of keeps moving back and kind of moving the wall back. You can almost think of it like 2 armies coming at each other.
So it's like it's retreating.
It's like retreating, exactly. And hopefully it gets to the point where it builds up Helm's Deep from Lord of the Rings, and they're protected in there, and it goes no further and you shall not pass. But a lot of times it doesn't, because the people that have these wounds, I'm making really cheesy references here, this is great. But the patients have these wounds don't have the ability to build up those walls to stop it. Like for you, you might get it, like you say you get a really bad wound on your toe and it does get necrotic. Because your immune system is healthy, it'll build up that wall to stop it from going far. But somebody that's got diabetes or, why am I drawing a blank here? I just talked about it. Atherosclerosis or arteriosclerosis, where the arteries are damaged. It doesn't know how to build that wall as well. And so that it just keeps retreating until it gets to a point where it either takes the whole foot or it keeps moving. I've seen people with diabetic injuries that cause them to have, below knee amputation done. So it's just our bodies, when we don't take care of our bodies don't take care of us either. Right? Does that make sense?
Yes, that makes complete sense.
Cool. So here we're looking at kind of the epithelialization, right? Where the cells kind of migrate. And again, the best way for a wound to heal is from the outside in. If it kind of closes up, it makes things better. What can we do in healthcare to help those wounds come together?
Band-Aid?
Stitches and Band-Aids. Yeah, right?
Crazy.
They make those things called butterflies, right? That are those little kind of strips that you can pull together. And if any of you guys ever played sports, we use them a lot on sidelines for somebody that gets a cut on the forehead or something like that. Just to kind of squeeze those together, you put the Band-Aid over it and it brings it together until we can get something long-term in place. Bandages are a great example. Stitches, staples, right? Or the really bad ones. Those, I always, whenever I see somebody that's got staples in them, I just go, oh, that scares me. I don't ever want staples. I've had lots of stitches in my life, no staples, thankfully, knock on wood. Also nowadays we have this stuff called new skin, right? Has anyone seen that, or does anyone have that at home? Yep, there we go. Crazy glue. Well, new skin really, Riley, is just crazy glue. It's just that they've realized that for years, us rednecks have used crazy glue and super glue as ways to close wounds. And now they're like, well, let's just, sanitize it, call it sanitized, crazy glue, and sell that. I have a scar on my head where they should not have used new skin before, where I banged my head on stairs. I ended up with this huge cut across my head. It was originally invented for wound closure, right? Yeah, so the doc squeezed my head together, put the new skin in, put these clamps on my head, hold my skin together until that new skin dried, and now I've got a nasty scar from it because he shouldn't have used that on my head. But that's beside the point, not bitter at all. But yeah, I mean, when I go out hunting or something like that, one of the things I keep in my little first aid kit, because if you don't have a first aid kit when you're going hunting, you'll need one. If you do have one, you don't need one. One of the things I keep in there is just a little tube of super glue. So I get a splinter, I get a cut, and super glue it, and it keeps stuff out. And it usually helps until I get home. But yeah, the closer we can get those wound edges together, the better. Why do you think we might not close those? Let's say I've got a really bad wound on a patient and I don't want to, why would you think maybe I don't want to close it off?
Bacteria.
Yeah, right. So maybe I noticed, hey, that infection, it's got an infection. Okay, the TV just flashed really brightly. I don't know what happened there. Sorry, squirrel. And I've got a bacterial infection in there. I've got to get that bacteria out before I approximate those edges. Because if I don't, all I'm doing is closing the bacteria in the body. And then you end up with, when we're back in the lab, I'll show you, I've got a nasty scar on my neck from where I did my I have an anterior and posterior disc fusion. But I got a really nasty infection in the anterior portion. And the doc just said, oh, well, we'll just close it and it'll heal itself. Well, it ended up pushing the stitches out and it got really nasty and infected. They ended up having to clean it out, recut it, and then re-stitch it because the doctor didn't do things right. Not bitter at all. But if we have that bacterial in there, we don't want to do that, right? So as the wound starts closing in, the square picture here is basically showing, if we've got this nice big square, I guess technically a rectangle wound, the wound's going to slowly start moving in, right? Until it can completely close the door on the wound. That would be the ideal way for a wound to heal. It doesn't always heal that way, but that would be the ideal way. That leads us into that maturation phase where things start getting back to normal, right? This is the longest phase and it can persist for more than a year after injury. This is restoration of a tissue to its prior function. So this is where you start getting rid of the tissue we no longer need in that area and laying down remodeled scar. And a remodeled scar is always, when you have a really kind of big wound, that remodeled scar is never going to be as strong as that original tissue. A lot of times, if you look in the books, they say anywhere from 80 to 90% of its original tissue viability, meaning that if you have like my scar on my neck here, it has about 80 to 90% of the tensile strength of the skin that was there before. So this is where then I maybe injure that again and it opens back up. Well, the next time it heals, now it's lost another 10 to 20% of its structural integrity, and it can keep getting better if you have a wound that constantly comes back, right, where it just heals over. And if we don't lay the right amount of matrixing under it, right, and we end up where it's not. So what does lysis mean? I mentioned that a couple of times, but maybe I just thought of it. Maybe I didn't mention it.
Dissolution, separating.
Yeah, it's breaking apart, right? Right. In 45 minutes, I will lyse this class. We'll break apart and we'll be done. Right. As those cells that are underneath that are no longer needed lyse and kind of get reabsorbed back into the surrounding tissue, if it keeps producing stuff under there, if it keeps producing that collagen matrix that we don't need anymore, a lot of times you end up with those keloid or really nasty looking, what we call hypertrophic scars, right? That's where those scars gain abnormal pigmentation, right? The easiest example you can have of one of these keloid or hypertrophic scars in the very, very minor sense is stretch marks, right? I'm not going to ask if anyone has stretch marks in here. That would be considered rude. But I have stretch marks on my hip because I used to be a lot bigger than I am now. And I'm still pretty big, but I'm not as big as I used to be. And so that skin had separated out. Well, now it's back together and I've got these nasty kind of scars there. And once they're laid down, they're kind of there for life. Oh, I can put cocoa butter on them and they get better. No, they won't. You just hide them, right? But that hypertrophic scar just won't be as functional. And if you get a really bad keloid or hypertrophic scar, it can be as little as 10% as functional as the original tissue. So that's why scar management with patients, we really, really want to take care of. So the type 3 collagen is going to come in and say, okay, I'm done. I'm going to lyse and get reabsorbed. The type 1 collagen, which is closer to most of the collagen we have in our body, is going to come in and build the bricks up under the type 3 that was there, and the type 3 will vanish. That's the ideal way for it to happen. If we have, it says here, high oxygen exposure favors hypertrophy, meaning that if our body gets the appropriate amount of oxygen, it will build up, but we can also negatively affect that. If you have a patient that maybe has a wound that's healing and you give them too much oxygen, it can actually increase the chances of that scar going keloid or hypertrophic. So there's that delicate balance. I always joke with when I'm teaching wound care is your wounds have to be kind of like Goldilocks. It can't be too much of this way. It can't be too little of this way. It has to be just right. And if it's just right, the tissue will heal fairly normally and you'll have a minimal scar. And you know, a lot of times patients when they're doing wound care, and I'm sorry not to pick on you ladies, but especially ladies when we're doing wound care, that's one of the big things that you're worried about is this going to scar badly? And the best thing I tell them is if you follow the plan, if you trust the plan, follow the plan and do everything I tell you to do, we can minimize that scarring, right? But if I have a huge gaping hole in my chest from maybe a burn or something like that, it's not going to heal and look normal ever again. The best I can do is get it back to as close to normal as possible by moving that scar. So once we talked about kind of the normal process, going through inflammation, proliferation, remodeling, maturation phase, there are patients that end up in what's called chronic inflammation, right? Usually, and these are kind of standards we use in the hospital, an acute phase is no longer than more than 2 weeks. Subacute's 4 weeks. If it's anything longer than that, we typically consider it a chronic injury. Some of you guys, I'd be willing to bet if I ask, it's okay, Riley. You'll get, I'm recording it too, so don't worry about that totally. How many of you guys have a chronic low back injury in here? Does anyone? Okay.
Yep.
And by chronic, I mean either it hurts every day or you do just the slightest, stupidest thing, right? And it hurts for the next couple of days, right? It's really, yeah. Ironically enough, most people get into physical therapy that have chronic injuries. It's kind of amusing. It's kind of like me with my psychology degree. Most people get into psychology to figure out what's wrong with them. But yeah, so you end up in this kind of chronic inflammation phase where, you know, it only takes a little bit to throw you back into that acute phase where it really hurts, right? So a patient that ends up in this chronic inflammation phase can get stuck there because maybe they keep re-injuring the area. I had a patient once when I was an outpatient here in town who was an Amazon worker. And he had actually torn some of his erector spinae in his lumbar region. And I said, okay, you know, you've torn the muscle at this point. There's only one thing we can do. We need you to rest in order to heal it. He's like, well, okay, I can rest from Amazon, but I still got to work on my UPS job because they're not going to give me workers' comp, whereas Amazon's going to give me workers' comp. And he kept coming to therapy and he kept saying to us, why isn't this getting better? It just seems to be getting worse. Well, the reason was he was stuck in this chronic inflammation phase. Every time we got something a little bit better, it got worse. And we just kept this vicious cycle going. And he can end up stuck in that forever. If it's a wound that gets stuck in that, you can end up with that wound literally forever. Some patients that get diabetic injuries or diabetic ulcers on their feet, that wound never heals. We're constantly, consistently doing wound care on it for years. The big one I see a lot of times is arterial wounds, which are problems where you get wounds on that lateral aspect of your leg from arterial insufficiency, right? It's basically your tissue starving. Those wounds, once you develop one, and maybe it heals, it gets better. Well, the problem is it died because it didn't have enough blood supply. You didn't fix the blood supply problem. So those wounds are going to keep coming back. You end up in this chronic inflammation phase where it just keeps getting worse and worse. Fibromyalgia. How many of you guys believe fibromyalgia is a real condition? Does anyone believe it's not a real condition?
I'm not sure, and I was diagnosed with it in like middle school.
Okay. Does anyone not believe it's a real condition? Just curious. I know you said you're not sure. Is anyone one of those? So I'm of the belief that here's part of my belief on this disease. If your patient believes they have it, they probably have it. Even if they don't physically have it, in their brain, they have said, I've got fibromyalgia, and they've taken on that disease, right? It sounds like you didn't take on the disease, which is actually a good thing on your part.
Yeah, like all the feedback that I got was like, well, we can't figure out what's wrong with you, so we're just going to call it
fibromyalgia. That was, let me guess, was that about 5 to 10 years ago?
Like, try like 15, 20.
Okay, so we were a little older than I expected. That's all. Sorry. Yeah, so that was the beginning of the peak of the fibromyalgia craze. But about 5 to 10 years ago, it was really kind of crazy, where we're throwing fibromyalgia at everybody. You know, you got a car accident, you've got fibromyalgia. But fibromyalgia is a consistent state of inflammation. It does exist. We actually have tests for it. There are ways we can test for it. But one of the precipitating events, you'll learn this about in patho, one of the things that has to be in there at some point is there has to be a precipitating event to it, an event that causes it. It doesn't have to be a car accident. It could be domestic abuse. It could be psychological abuse. Whatever that may be, that triggers the body to get stuck in an inflammation phase. And we can treat the pain, we can treat the aches, we can treat everything till we're blue in the face. If we don't deal with that initial condition, we're never going to get better. So yeah, I think fibromyalgia exists. I think it's overdiagnosed sometimes, but a lot of times these patients get told it and they get stuck in it. Yeah. GIs do that a lot. Yeah. You've got gastroenteritis. You've got inflamed gut. Great. Thanks. That tells me, what do I need to do to fix it? Good. Yeah, I mean, that tells you you've had a history of injuries probably by doing that, because nothing against, but ice skating and gymnastics is not very easy on the body, right? And so I'm guessing, like I was when I was in the martial arts, if you got injured, you know, you just walked it off. You went right back to doing whatever you're doing. And the problem is you never got out of that healing phase, and that gets you stuck there. You still could have fibromyalgia. It could still come back to haunt you sometime down the road. But if you make sure that you're taking care of yourself, you can avoid getting stuck in that. And this is where we kind of got to work with these patients and got to help them understand, yeah, you're stuck in this inflammation phase, but it doesn't mean you're dead. Right? And the one thing we've learned about patients that are stuck in chronic inflammation is they don't want to do anything because they're afraid it's going to hurt. Right? They don't want to walk because they're afraid it's going to hurt. They don't want to exercise because they're afraid it's going to hurt. And then because they don't walk or exercise, what happens to the inflammation?
Gets worse.
Yeah, it gets worse. It's this vicious cycle, right? So, you know, here I am, I have an injury. Because I have an injury, right? I stop doing things. Right? Yes, exactly. Motion is lotion. You're exactly right. I'll say that quite a bit. Because I stopped doing things, the inflammation goes up, right? Because that inflammation goes up, I stop more. And then I just, now I stop more. So now I get up to get out of the chair and now I strain my back. So now I get another injury. Because I've got that injury, I stop doing things. Because I stop doing things, my inflammation kicks up. And you end up in that, exactly right, Joe, that negative feedback loop. And what we as therapists have to come in and say is, yeah, I know that you have an injury. I'm not discounting that. I know you have inflammation. But if we don't axe these, you're never going to get better. And motion is lotion. You're exactly right. And one of the other things you'll hear me say is you can't mobilize until you stabilize. So if we stabilize their condition, we can get them mobile and hostile and agile. So the same thing happens here when they're stuck in this chronic inflammation phase. They just get stuck in that negative feedback loop. And for the average patient, they don't know how to get out of it. I'm also going to say that in the average physical therapy clinic, we don't handle patients in chronic inflammation very well. And when I say average physical therapy clinic, I'm talking about one that is just based on your traditional orthopedic outpatient physical therapy. Because what we do is we just try to treat the symptoms instead of looking at the holistic approach of what's causing them to get stuck in those symptoms. And that's why having somebody that's specialized in chronic pain in your clinic can be, or chronic pain or chronic inflammation, can really help you out. Because if you are there and you've got that person that's really, really, really good at dealing with these patients, they can help show that patient how they're stuck in that loop and how they can get out of it. What we've got to build is an off-ramp, right? We got to build an off-ramp where they can take their car and drive it away. And when we show them that, it's amazing how many of the patients start getting better quickly. You're not broken. You can still do stuff, but it hurts. Yeah, it's going to hurt. I appreciate you're saying it hurts. Yeah, absolutely. Yeah, there are specializations within the APTA for chronic inflammation and chronic pain. So there's a lot of different branches, right? And if you ever get into the APTA and stuff like that, you'll find out they call them silos because they exist in a silo. I don't like that idea because to me, a silo is a closed off thing. And if it's closed off, you can't be open to other ideas. But you have silos. You have the acute care silo. You have the chronic wound care silo. You have the short-term wound care. You have these silos that you can all go in and kind of get some specializations in. Why do you think a lot of PTs and PTAs don't specialize in chronic pain?
Because it's something we're still studying and learning about.
That's part of it. Good, right? Yep, absolutely. And you guys will have a nice 4-hour long, the other group has that on Monday, the nice 4-hour chronic pain lecture from Mr. McKeever that some of them will say gives them chronic pain. But what else? That's one reason.
Would it be because pain is different to every patient, so it's hard to...
Yeah, think about that. And what's different to every patient, so every patient presents differently, but for those of you that have done your observation, have any of you saw chronic pain patients? What do those patients typically look like? Are they the patients you really want to treat?
No.
Yeah, exactly. Like, I don't want to be mean, but no, right? Those are the patients that are coming in, it's Linus, or not Linus, what was the guy? Pigpen from Charlie Brown, right? They come in, they're disheveled, they're not exactly all together. And you're like, so how are you doing today, Bob? Oh, the world sucks. My life sucks. How's your pain? Oh, it's the worst it's ever been. And when you're treating that on a daily basis, patient after patient after patient, think what that does to your psyche, right? You just get beat down. It's a rough place to be in, right? And the other thing is somehow or other, you have to find it in yourself to be that kind of bubbly ray of sunshine to those people. And they often don't like that, right? You're happy and trying to help them. They understand in their mind that you're trying to help them, but they're like, God, just stop, right? It just burns their biscuits because they're sitting there going, how can you be so happy when my life sucks so bad? Some of you probably have friends like that. I know I have a couple of friends that are exactly like this type person. Even they're not in chronic pain. They're just what I call those VDPs, very draining people, right? You have your VIPs of your friends, your very important or very influential people that, when you need picked up, you call them. And then you have that one person that your phone rings and you look at the caller ID and you're like, oh, right? Yes, vampires, psychic vampires. Well, these patients can be a little bit psychic vampires to you, right? Because they drain your happiness out of you too. And you see 10 of them in a day, and then you go home and your spouse, your significant other says, "So honey, how was your day?" And you're like, "Guy from the clinic, you just have no idea what I deal with on a daily basis." The other thing is, a lot of the stuff, like they said, is not well researched at this point. We're still learning, right? The brain, we've only unlocked, I think, 13% of our brain or something silly like that. I'm probably off on the percentage at this point, right? But what happens if we can unlock some more of that brain and figure out how to use more of our brain to treat this? Could be interesting. So what can affect our healing? Local factors can affect our healing, right? And when we say local factors, not only is it local to the wound, right? So let's say I have a wound on my arm. Is that going to heal differently than a wound I get on my bottom?
Yes.
Yeah, absolutely, right? Is there going to be different things that a wound that's on my butt might deal with that my wound on my arm doesn't deal with? Right? Fecal coliform. You go to the bathroom, that fecal coliform goes everywhere, right? Maybe urine, stuff like that. So the local factors the other local factors are also local to where the patient lives. Right after school, I did a, what is it called? A mission trip to Haiti with one of the docs I worked with. And it was interesting. He's putting a clinic in the middle of Haiti that he goes to. I think he goes to it about every 6 months. And it's the only clinic for like 500 miles or something crazy like that. And it's only open so often. So people literally walk for days to come to this clinic. We're spoiled. I mean, you pretty much can throw a stone out of your house and hit a rapid ER somewhere for the most part in Vegas, right? These people may have to, I remember there was a lady that came to the clinic that wanted to get a prosthetic for her little boy, and she had carried him for 2 days through the jungle to bring him to the clinic. And it's just, those local factors also play into it. Yeah, right. It does kind of make you, and doing those trips really has made me kind of appreciate how spoiled I am as an American. And also, there are multiple other things I could throw in there as well. It does make you a little bit humble, right? But also, let's think about Las Vegas. What do we have in Las Vegas that could make wound care healing worse? What's the climate like?
It's very
Minus.
Yeah, it's nasty, right?
alkaloid.
What's that? I'm sorry.
Alkaloid.
Yeah, very alkaloid, right? So it's going to affect the overall pH of the wound. Dry, right? Especially during winter, when you would think that maybe it would get a little bit better, except as I understand, you guys had a little bit of snow this past week, so huzzah. But it's really dry. It just doesn't heal right because of that dry weather. So we do have to donate moisture to those wounds. Coming from where I came from in Pennsylvania, I had the opposite effect, because in Pennsylvania, during summer, it's 95 degrees outside and 99% humidity. It feels like you're walking through Campbell's soup all day long. Right? And so now that's too moist. Now the wound gets other problems to go along with it. We have some weird flora and fauna in Vegas, right? We have cacti and all the fungus that is associated with cacti that can easily get in wounds. There are external factors that can lead to wounds not healing right. Does the patient actually take care of the wound? Do they have access to wound care supplies? I mean, you guys probably take a little bit for granted that if you get a cut, you can go throw a Band-Aid on it. But it may not be that way for everyone. And of course, systemic factors, either dealing with systemic inside them, or we can talk about systemic factors outside in the environment as well, right? So systemic factors are maybe your body doesn't heal right, but does socioeconomic status play into a patient getting better?
Yes, very much so.
Yeah, very much. I just read an article today. I want to say it was Memphis. I can't remember exactly where. About a fire chief who went to 3 different hospitals complaining of chest pain. And all 3 of them basically said, there's nothing wrong with you. And the last one sent him home with Advil. And he came back in one more time and his wife was begging, please help him, something's wrong. And the triage said, look, he's been in here once, he's been to 2 of our other hospitals twice. We don't find anything wrong with him. There's nothing we can do for him. And she wheels him out. As she's wheeling him down the hallway, his heart stops. Right? Well, you might ask, why did that happen? Well, there's multiple factors that can go into that, right? That's the American way right there, shoot. But, you know, he's African-American. And there are study after study that shows, you know, African-Americans, specifically men, are typically not believed when they have problems, when they go to see doctors. And so that creates an inherent distrust of doctors. There's some crazy distrust going on right now with the whole Hank Aaron death. That Hank Aaron died because he got the vaccine. No, he actually had COVID beforehand. But that's beside the point. Now you put that inherent trust in the community and they don't trust the vaccine. Same idea here. There are systemic factors that lead to that. And as healthcare providers, we have to break it down. There have been those patients, and you guys will have this, in whatever job you've ever had before. Has there ever been a time that somebody walks up to you and you instantly judge them? I mean, I can admit it. Yeah, I admit it. There have been times that somebody's walked up to me and I'm like, oh, not another one of these. Right? And then the person turns out to be something totally different from what my observation of them is. So as healthcare providers, we've got to work on our own inherent biases and work towards treating everyone as if they're just a person, because they really are. And then you feel bad. Exactly. There is unconscious bias and it exists. Unconscious bias doesn't exist just with one race. Unconscious bias exists across all races, all ethnicities. There's an unconscious bias in everyone. Yeah, no, I don't ever misjudge Karens, but just kidding. I feel bad for people that have the Karen name now. They've just gotten a bad rap. But yeah, the Karen situation that we have nowadays kind of shows you the first time somebody says, I need to speak to the manager, you're like, oh God. I was reading about one of my friends who does retail sales. The lady walked up to him and he's like, as soon as I saw her, I knew she was a Karen and this was going to suck. And the first thing she asked for was my manager. And I gave her a little bit of attitude. And it turns out she was going to compliment me to my manager. Right? We all have inherent biases. And in healthcare, we've got to get over those because those are systemic factors that can affect our patients' healing. They really can. Type, size, and location of an injury. If you got a patient that has a burn across 80% of their body, is that going to be a problem? Sure.
Yes.
Right? But then I asked this question in my other class, the other group when I was working on it. What if that's an 80% and it's a really superficial burn? It's just the outside of their skin. But then the bed beside them, they have a patient that's 16% burnt, but full thickness. It's burned all the way down to their organs. That person with the 16% is going to end up worse off than the person with almost a full body burn because of the type of injury, right? It's just kind of the way it works. This type of injury can affect, right? Somebody that gets shot by a gun, although it's traumatic, right? And it's especially if it hits organs or something like that, but you get a shot with a gun through the shoulder and it's, high caliber, it goes through and through and goes right out. You're probably luckier than somebody that might get stabbed. So there are things that can affect those overall injuries, right? If I get stabbed in my heart, I'm probably not going to live as much as if I get stabbed in my foot. There's all kinds of things happen. Infections. The one we have to worry about are what's called HAIs. Does anyone know what HAI stands for? It's also nosocomial. So I'll type that in here.
Well, I know it happens in a hospital because it's nosocomial, but I have no idea what it stands for.
Hospital acquired, I can't spell today. Hospital acquired infection. What's our rate in the United States? Does anyone know?
Terrible.
Terrible. That's a good way of looking at it. About 23%. So if you go into the hospital, you have probably about a 1 in 4 or 1 in 5 chance of getting a hospital infection. Think about that for a second. That's just crazy, right? But any of the other infections, and then we're not only breeding those hospital-acquired infections, but then we're breeding these super bugs that we can't even treat, right? MRSA, VRSA, all these types of antibiotic-resistant infections. And vascular supply, right? If it's a toe, the body may just decide to shut it off and lose it rather than doing anything else. So primary, secondary, and tertiary healing. So primary healing is typical healing we think about when the wound closes in. When the wound edges approximate, they come together, it heals from the outside and comes in. Secondary healing is typically thought of from the bottom up, right? So that's where the wound's gonna fill in and fill in. Secondary healing, again, is more likely to leave a scar. The tissue is usually a little bit less viable. Primary intention is our goal. If we have a patient that's healing by secondary intention, we get all the infection out of it, and we can close that wound surgically, that allows them to heal a lot better. There is a tertiary intention that's not up here, and that's the one I talked about a little bit ago when I said that sometimes we leave wounds open. Tertiary intention is delayed primary, so we leave it open until we can close it. So when you think about primary versus secondary intention, primary intention's outside in, secondary is kind of from the bottom up. So physical therapy, what can we use out there? Almost anything. We can use cryotherapy, thermotherapy, ultrasound, EM radiation, light, electrical currents. All of them have specific treatment protocols. And not only do they all have specific treatment protocols, but they also have specific protocols inside each modality for acute patients versus chronic patients. When we have an injury, there's still going to be a part of that injury phase where we do want them to be kind of immobilized, where they're not moving around a lot. In that case, we may use something called a CPM, which is a passive machine that will move them without the patients having to contract muscles. We do that a lot with patients that get total knee replacements, where we put them on what they call the torture device that bends their knee for them. That way we can allow the wound to heal, but still get some motion going there, because we know motion is lotion. But let's take a look at something like an acute infection or an acute wound. When we have an acute wound or acute injury, we should be thinking more along the cryotherapy route. Did that after hip surgery? Yep, exactly. So, and it's amazing how much those do help, but we'll talk about that when we get to that in third semester, where it may not be as effective as we thought it is nowadays. But in the acute phase, a lot of times we're going to think more along the cryotherapy route, right? Where we're going to calm down inflammation with cold. So we may do ice packs, cold packs, ice massage. We may do the Iceman machines or the Game Readies to kind of cool down that inflammation. When we start going to subacute and get into kind of the long-term or the chronic patients, then we start thinking about heat. And this is where we have to be really aware of this, because let's say that you injure your ankle today and you injure it pretty bad. Heat feels really good on it, just because heat gives us an effect that we call the gate control theory, which you'll talk about in pain, that kind of relieves the pain. Well, what's heat going to do to inflammation?
Make it worse.
Yeah, make it worse, right? And this is the problem I see in a lot of clinics. And I don't know how we ended up on this in clinics, but the patient comes in for therapy. They go on heat as soon as they come into the clinic for 10 minutes. They do all their exercises and they go on cold before they leave. Has anyone seen that in the clinic when you did observations? Yeah, right? Seems normal. But if we have an acute injury, that heat is actually going to make things worse, because that's going to kick the inflammatory mediators up. So we may not want to put them on heat as soon as they walk through the door, right? We may use E-stim or something like that, or maybe we stick with cold. Why don't we use more cold? Because patients don't like cold. Some patients are weird. I love cold. But some patients really don't like it, especially your little old millies, you know, the 5'1", 75-pound little old ladies. They hate cold. Even though it may be better for them, they just hate getting that ice pack on their body. They want that hot pack. And then even thinking about that, so let's look. So we're going through, we have ultrasound, we have electromagnetic radiation, light, and electrical currents. Think about this just from a physics standpoint. If I'm in an acute phase of inflammation or even infection, what's going to happen if I give the area energy?
Gonna spread?
Yeah, right? I'm going to use a good example of this. Has anyone heard of Bell's palsy or facial nerve palsy before?
Yes.
Right. We know now that Bell's palsy is typically caused by our buddy herpes, the herpes simplex virus, right? It's where the face kind of droops and gets all kind of messy. We don't know what specifically triggers it, but we know what is one of the triggering factors for it. That if you've had a cold sore in the past, you may get Bell's palsy later in life. It just happens. You know what we used to do to those patients? We used to put electrodes on their face. Right? The mountain from Game of Thrones, exactly, right? We used to put electrodes on their face and make their face make funny faces at us. But then we realized, yeah, right, Riley's like, it's terrible. We just realized we're giving a virus energy. And then we were like, well, why isn't this patient getting better? Well, because we're speeding along the infection, right? You've got a patient with cancer and you put heat on it. It's going to help spread the cancer. So we have to be aware of what our patients have and be really specific about our modalities we use. Does that mean we can't use electricity in an acute care or an acute phase? No, but we may not use full on, you know, burst Russian where their face is twitching, right? We might do something a little bit more low key like TENS or something a little more low key like IFC or pre-mod. So we have to understand all of this comes into play. This is the difference between you guys being, if any of you are techs, and being a PTA. Because and I would never ask a tech to do any modality. That's totally against my creed. You're not supposed to do any of my modalities. That's my job. But if you ask a tech how to go to ultrasound or go to something, they typically only know one way to do it. They know whatever way they were shown to do ultrasound. They don't know one way that they're shown how to do E-stim. That may be the wrong way for that patient. And that can end up kicking the inflammation into craze. Age, obviously, the older you are, the harder it is to heal, right? We know that from kids, right? We've seen kids fall down flights of stairs, get up and go running. Where we fall out of our chair, we break our hips and we're in the hospital for months. Diabetes, we talked about already, right? And other immune systems. Medications can slow down healing, especially stuff like anticoagulants that stops the blood from healing. The other thing we often forget is nutrition and hydration, right? I'm sitting here drinking Coke Zero, so I'm just about as guilty as anyone else. This is not hydration. This is my caffeine kick, right? Hydration's your stuff that donates fluid back to the body, your waters, your Gatorades, your Pedialyte, stuff like that. We all need more of that in our bodies because our body needs hydration to function. We also need nutrition, right? We need a nice balance of all of our standard food groups, our carbohydrates, our proteins, our veggies. If we don't get those, we don't heal right. Also, we're looking at things like the regeneration capacity of the tissue, your tongue. Has anyone ever bitten their tip of their tongue off? Truman's like, ugh. I actually did it once in a martial arts match because I forgot my mouth guard and I got caught with an uppercut. And for some reason, I had my tongue between my teeth and bit the tip of my tongue off. Well, does that mean my tongue gone forever? No, I got a normal tongue, right? It was a little bit more regenerative. Your liver has some signs of regeneration, right? But your kidneys, not so much. They start getting infected and stuff like that. They typically don't heal. And then all kinds of tissues have different capacities for healing, right? Cartilage, tendons, and ligaments that are typically avascular, not having their own blood supply, don't heal as well as something like muscle or bone that have blood supply. And even in bones, depending upon where you are on the bone, in the compact cortical or the ends, wherever you happen to be on the bone, certain parts of the bone heal better than the other parts of the bone, right? If you're dead center in the middle, you may not get as much blood supply as something out towards the end caps of the bone. So cartilage, like I said, lacks the lymphatics, lacks blood vessels, heals a little slower. I said the same thing for tendons, right? With tendons, if we're going to heal them, if you get a tendon repair or ligament repair, a lot of times you're going to be immobilized for a while. You guys ever seen patients with ACL tears? And they're walking around in that big old brace, not letting them move because we want that tendon to heal. Muscle can be injured by trauma, strain, muscle disease, anything like that. Healing is pretty quick in muscles because it has a regular blood supply. They proliferate, they differentiate, and they grow. There's a lot of theory we talk about when we talk about hypertrophy or growing of muscles that we actually don't get new muscle. It's just the existing muscle getting larger. But sometimes if your muscle's healing, you might get something weird called myositis ossificans, which is where bone grows into the muscle. Right? It literally becomes calcified. If that happens, that muscle is going to be seriously, seriously, what's the word I'm looking for? Not conflicted. I'm losing my brain right now. It's going to have serious problems healing. We'll just go there. So bone, another thing that heals, right? Bone takes a long time to heal. Why? Well, because it's skeletal. It has to form a soft callus, a hard callus, and remodeling in order to heal. And if you look, a bone that's fractured could take months to years to heal. I mean, I'm lucky I haven't ever broken any major bones other than my neck. I guess that's considered a major bone. I broke my neck twice now. I'm not very good at this whole thing. But then there's the theory of why did I break my neck twice? Probably because I broke it once. When the bone heals, it takes a while to get back to its normal thing. Right? Sometimes if you get a bone, like I had a small fracture in this ulna right about here. And I can actually still feel where that fracture was because I've got a little lump there, right? That's still part of the hard callus that stayed there. And it's just a little bit different than all the other bone. So here we have a patient that's JP, a 16-year-old student who injured her right ankle 1 week playing soccer, was treated conservatively with crutches, rest, ice, compression, elevation, so RICE, and NSAIDs, and she's currently having limited improvement. She still has ankle pain, x-rays show no fracture. Her physician diagnosed her the injury as a grade 2 lateral ankle sprain. She comes to your clinic with orders to evaluate and treat, right? She sustained this injury doing a cut drill. So a cut drill is where they kind of make those quick, rapid changes. She noted an audible pop. What's a pop tell us probably?
Dislocation.
Yeah, dislocation or tear, right? And that's usually bad. She had immediate pain and swelling. She reports her pain has decreased from 8 out of 10 to 6 out of 10, but the pain increases with weight bearing. Well, one of the first things we're going to have to do with this patient, we know that they've got a pretty bad sprain, right, of that ankle. One of the things we're going to have to do is, first of all, calm that strain down. And I talked about that briefly, right? We're going to use ice, cold modalities to kind of calm that inflammation down. If we put her on a hot pack, what's her ankle going to look like later on?
So puffy.
Yeah, so puffy and swollen, right? We may do a combination of heat and cold to pump some of the swelling out, but we've definitely got to get her off that ankle for a while. We may have to provide her with some stabilization while she's walking. What might we want to get her for the ankle?
Crutches.
Crutches, right? I think somebody just said a brace, right? All that to kind of offload a little bit of that weight on that ankle because she already rolled it once. If we don't kind of support it, she's probably going to roll it again and make it worse. She's an athlete. What do you think the chances of her healing normally are going to be?
Honestly, I think she would have a normal than better chance because she's doing a lot of activities. So I feel like the blood cells and everything are very active to help with the healing. Good,
right? And, again, this was going to come into the fact of if she's actually injured that area before, because if she's injured it before, may not heal as well. This is the first time she's an athletic person. She's, what did I say? She's 18, I think, 16. Overall, this is going to heal pretty well for the most part. Now, there are good things that can cause complications with this, right? Who's going to do the evaluation on the patient?
The PT.
The PT, right? We're not going to be involved until that evaluation is done. So what do you think? So because we're going to have short-term and long-term goals. What do you think some of our short-term goals are going to be for this patient? What's the first thing we want to calm down?
Inflammation.
Inflammation, right? We want to get the swelling and the pain down. Because until we get rid of that, she's not going to do much else. Right? So we're going to kick those down. That also involves probably a little bit of her staying off that foot, which means we're going to have to be kind of those cheerleaders in the sideline going, hey, JP, I know you want to get back to practice, but if you don't do what I tell you, you're not going to get back to practice. Athletes, do athletes want to get back on the field immediately?
Yes.
Yep. And so we've got to
Sometimes
convince
that's
her.
more like parents, though.
What'd say?
So sometimes that's more like parents.
Right.
Like,
And there's the other thing. We got to get mom and dad convinced. Now, the good news is she's 16. So that means mom and or dad have to be coming to the therapy session with her, right? Because she can't consent to any of our therapy because she's considered technically a child. We have to get mom or dad to consent. So that's where we kind of have to give updates to mom and dad saying, hey, you know, we're now at about 2 weeks out. She's starting to look good. You know, I'm okay with her starting to do some walking drills and some walking around school without her crutches a little bit. Still no running, still no this, still no that. Maybe she can do a bike. We have to be really specific with these athletes because otherwise they hear I can walk and that means they can go back to practice. The parents hear that. Parents are like, oh, she can walk. That means she's really good to get back on the field. You know, or you'll hear well, if she doesn't get back on the field, she's not going to get that scholarship. Yeah, but she might not be able to play ever again if we don't treat it. So we have to be a little bit aggressive with this patient. Long-term goals, we're going to work on getting her back to regular play, right? And this could be fun because for me, I literally know very little about soccer. I'm not, I don't know. I don't know much about it. But what are some of the things I'm going to have to incorporate later on in her therapy session? Soccer activities, right? She says here, while dribbling a ball, I've got to learn what dribbling is. I've got to learn what kind of a cut drill she was doing. Because in order for me to get her buy-in, I have to get her doing some stuff that gets her back to normal. Needs to chest slaps, right? Doing up downs all day long. That's what I know from football. So you may have to become a little bit of a student and go, you know what? I'm going to have to go watch some soccer drills on YouTube. See what these people do. You may have to learn, well, what if I'm watching soccer drills and I find out she's a goalie? And I've been watching forwards all day long. I watched the wrong people. So I got to find out what she does. And this separates the good PTAs and the good PTs from the bad PTAs and the bad PTs. Is if we're willing to go that little bit of an extra mile and incorporate stuff that is her history in order to get better. She definitely has a good chance of getting better though. All right. That wasn't as bad as I thought it was going to be. Any questions? Is everyone feeling okay? You ready to get out of here for the day? All right, I think the officers were planning on meeting with me for a couple minutes here. I'm going to